when you take a look at this whole problem, not everybody out in the real practicing world is a pulmonologist or a pulmonary expert. And in fact, primary care is where all these people begin to encounter the healthcare system to begin with. So is it just the physician? Is there a team involved? Who's involved in the management of COPD out there in the texture of the real world?
Healthcare providers in general, from the person who does the first contact in the office, physician assistants, nurse practitioners. I mean, everybody's part of the team. And as Barbara emphasized, we have to change our chip. Our concept of, oh, I'm looking for a COPD in a 75-year-old male who smokes. No, forget about it. You have to look for a COPD in the 50-year-old woman who happens to smoke, don't smoke anymore, is coming with cough, and you have diagnosed with sinus, with allergies, with this and that. Do a spirometry,
okay, well,
make a diagnosis.
Let me stop you for a second, because this is a pie in the sky, kind of a cloud cuckoo land vision of medicine, right? Which is, oh, we're all part of a team and we sing Kumbaya. But in fact, does this work in the real world, Byron? Do all the primary care docs get a team together to do this? And if not, why not?
Well, I think Barbara could answer some of those questions. The thing I would stress is that most COPD exists in primary care. Right. I even think that those of us who are pulmonologists, particularly those of us working in academic medical centers, see a very skewed population. Most of the people we see are the frequent exacerbators who, after bothering their primary care physician enough, they say, well, go see someone else. We don't even see that many. I don't see very many of the non-frequent exacerbators until they've reached the point that they need to be evaluated for lung volume reduction surgery or chronic oxygen or lung transplant. So much of primary care, much of COPD is in primary care. But I want to stress, I do want to hear what Barbara says. I want to stress, I agree with Antonio. Increasingly, with limited time that you can spend with your patients, I think we will be seeing more of a team approach, potentially involving more respiratory therapists and other things. But Barbara might be able to give us some guidance as to what
else do you pull in? Respiratory therapists seem like a natural. Obviously, the primary care physician is steering the ship, at least at first. What are the other specialties you want to pull into this team?
Well, I want to step back. In rural practice, which was where I was for many years, it's great to have a respiratory therapist. There's one over at the hospital, which is 20 miles away. Most primary care people do not have respiratory therapists in the outpatient.
Well, that's what I was getting at here, too. It's wonderful to say I want all these things, but...
Right, but you don't have them. And when you talk about a team, maybe it's a team, but my team was more likely to be the receptionist, my MA. I couldn't afford nurses, so I didn't have very many RNs. Maybe there was one for 15 or 20 docs. And many nurse practitioners and PAs in primary care are practicing independently, especially nurse practitioners. They're out all by themselves now. And I think this is a great opportunity for education because, as you know, most residents in primary care don't get a lot of time with COPD. A lot of these other people have had no education about COPD at all. So we have a long ways to go to help support what they're doing.
So what I'm hearing is that there's a lot of little silos here. There's the primary care.
That's right.
There's the nurse practitioner, and maybe there's some sort of respiratory therapist somewhere in the vicinity, maybe not. And by the way, where do pharmacists fit with all this?
Well, pharmacists could be very, very helpful, but they're also extremely busy, and you talk to them and they say, well, I really don't have time to even talk to the people because I have to check through all these prescriptions. So a whole lot of pharmacists, unfortunately, are still forced to stay back behind the counter and really never encounter the patient at all.
As an editorial here, folks, we work with PharmDs in my ICU. We've been doing it now for over a decade. Dramatic change.
Yeah.
Wonderful.
Oh.
Dramatic change for the better. Just editorial done.
I tell you, in primary care, we're extremely envious of all of that. And that's sometimes why we send the patient off to our academic colleagues, is we believe you're going to have more time, you're going to have other resources to educate the patient and support the patient. It is very difficult, even when they get in the hospital nowadays. I mean, they're in the hospital for 3 days, and they're really pretty sick the whole time. It is difficult to get that education in.
Byron fixes them in 2. I've seen him do it. But so if we think, and if we know that all these specialties working together can do better than anyone individually. And we think there's real synergy here, whether it's the pulmonologist plus the respiratory therapist, plus the primary care, plus the pharmacologist. What's the path from here, where all these little silos exist, to here, where we're working as a team?
I think we need to engage in education, what we call middle-level providers. I love to go when they invite me to the nurse practitioner, physician assistant meetings. I know that I will give a talk, and it would take me another hour and a half to get out of that room. The number of questions are unbelievable. And the questions are there in the front line every single day. And they come, and then people online say, listen, I have patients, we did this, how you doing this? So there is a huge need to reach these individuals, to teach them, and not only COPD, and many other conditions. We have to incorporate the other multiple conditions.
But you ask, what do we need to do? It's not just that we wouldn't like to have a team. I'd love to have a team. I'd love to have that time. It's called reimbursement. If you are not getting paid for all of these other things, it's very difficult to take that chunk out of your salary or whatever. So health systems, some of them have learned very well how to do this, and they do it very well in the inner city or in the metropolitan area. You get out to the smaller practice, and it's not done so well. So telehealth. I'm going to put a plug in for telehealth. We always think telehealth means a physician seeing a patient, but telehealth can mean a respiratory therapist educating a patient, a nurse educating a patient, a social worker or a psychologist interacting with a patient. So we can do this. We just have to be creative.
You were going to say
Yeah, I was just going to follow up on that, and the use of high-quality media, educational materials, which could potentially have a much greater effect. We really all care about the patient here. That's the focal point. And all the other interactions are secondary. But what's the best way to get to that patient in his or her environment? You know, what kind of media, what kind of information do they seek? What's the best way of communicating? And I think high-quality education, you know, saying that, but again, with all the innovation that's going on in our country, could be useful. Now, one of the problems with COPD patients is their literacy hasn't been the highest in the world. They're very similar to diabetes. And over the years, in terms of, I was always involved in education, either through NIH and others, we used a lot of picture books because the patients didn't have high, high literacy and to read how to use it. And then when you say, you know, the patient is given 3 inhalers and then the pharmacist is too busy, the doctors, nobody's training them. You hand them information that they can't read very well. It tells you the need to use apps, pictures, videos, all the various and the sundry things to make sure the patient successfully puts the drugs that are necessary into their body and they can get them. So,
well, then I think we're also really quite unrealistic about believing that the patient hears everything we say.
Exactly.
I mean, they're in my office for 12 minutes if I'm really lucky. And in 12 minutes, I have to discuss with them 3 conditions. Do you think they heard or were able to hear what I said after the first 30 seconds? Probably not. I mean, that is really difficult to absorb all of that and translate it into what it means for your life. So there are opportunities for education in their home, recurrent education. One of the things that I just learned about recently is something called VidScripts. And in this, you can record things that you tell patients multiple times, like how do you use your inhalers? And they can get it online through YouTube, but it's me, their physician, recording it. And so instead of watching Byron show them how to do it, and they've never seen Byron before, they go on YouTube and watch me. And so you can do this for all kinds of things in your practice. I think we need to start using, as you said, maybe social media.